Thank you, Cherie, for getting the recording on. This presentation will be recorded. It's the first time we're recording it in this particular format, so hopefully it all goes to plan. Once we have the recording, we'll be able to send that out to participants. We'll also be able to send out a copy of the presentation slides so that you're able to view those, and we'll direct you to the more concrete information that we're talking about today as well on the IOP website. So the name of our session today for the webinar is Paediatric Essential and Recommended Content Areas in Entry-Level Professional Physical Therapy Education, a Global Perspective. And we have, we have two of additional speakers with myself. So the chair of the IOP Education Committee is Donna Cech, so she'll be presenting some of the information to you today. We also have Yasser Salem, who is a member of the IOP Education Committee, and myself, I'll be talking to you a little bit, and I'm a member of the IOP Executive Committee, and I'm also the liaison to the IOP Education Committee. So just to be clear about what the IOP is, it's the International Organisation of Physical Therapists in Paediatrics. So when you hear us say IOP for short, that's what we're referring to. So before we get into talking about this topic, I would just like to welcome everybody from all over the world. We have about 27 member countries represented who are calling in today, or maybe watching the recordings if it's too early or in the middle of the night for them. And so I would like to acknowledge the Kubenberry clan of the Yugambeh language group as the traditional custodians of the land on which I'm presenting to you from today and from where we're hosting the webinar today. And I'd like to pay my respects to the elders past, present and emerging for their wisdom, teaching and cultural knowledge. And I'd also like to welcome everybody from all of the countries that you're from. You may be able to see from all of the words on the side of this slide that we have a fairly large group of participants today coming from Nigeria and also Taiwan, but many countries around the world. So hello and welcome, and thank you for joining our webinar today, the first of a series of webinars that the IOP will be hosting over the next 12 months. So the purpose of this webinar today is to introduce the IOP Paediatric Essential and Recommended Content Areas in Entry-Level Professional Physical Therapy Education, the statement that we've developed on that. And we'd like to discuss the rationale for the paediatric content areas and provide some examples and strategies on how to include and teach these components in entry-level physical therapy education curriculum. So we'll have some time at the end of the webinar to be able to discuss those in more detail and for you to be able to ask questions along the way also. In the background, there is also Cherie Ziski, who is helping us out today. So if you're coming in late, just a reminder to keep your cameras turned off if you can, so the bandwidth is reduced for participants who might be struggling with their internet connection, and also if you can keep your mics turned off throughout the session as well. And Cherie will just be helping admit people through probably the next 10 or 15 minutes of the webinar if they're entering late. The learning objectives for today's session, what we hope you're going to walk away from is that you'll be able to recognise the essential and recommended components of the paediatric content to be included in an entry-level physiotherapy education program, and that you'll be able to distinguish and discriminate between the essential and recommended, as well as the additional components of paediatric content to be included in the entry-level physiotherapy education. And also we hope that you'll be able to understand the rationale for including these and the background as to how they were developed in the first place and how they came about to end up in this education curriculum guideline. Just a little disclosure, when the process started for developing the statement itself, The name of our member organisation was World Confederation for Physical Therapy back then. And so throughout this document, you'll see the language of physiotherapy used. In 2020, the World Confederation of Physical Therapy changed its name and rebranded to World Physiotherapy. And so I just want you to be clear that when you see the words physical therapy throughout our statements today and throughout the presentation, it means exactly the same thing as physiotherapy. So both of those are included in the document. I'm going to hand over now to Donna, who's going to pick up here and start giving you some information about the background of the statement and how it was developed.
Thank you, Nikki. And I'd like to welcome everybody to the meeting. I'm very pleased that people from all over the globe have joined us, representing multiple continents. So this is truly a global get-together and one of the largest global audiences I've ever had the privilege of participating with. So thank you very much. What I'd like to do is just tell you a little bit about why and how this document came into being. And in 2011, the World Congress for Physical Therapy developed guidelines for physical therapists, professional entry-level education programs. And these guidelines were global, and they included statements such as, you know, the need to address and work with people over the lifespan. And the Organization of Physical Therapists in Pediatrics at that point, I was a member of the education committee then, decided we would survey our member countries and really get a better snapshot of pediatric physical therapy practice and education across the globe. So we conducted two different surveys. The first one, we had results coming in 2012, and the second one in 2016. And after we receive it, you'll see from the next slide that the 2012 survey was more of an open-ended answer questionnaire. It was a general survey of pediatric physical therapy practice in WCPT member countries. And it asked things like, how many pediatric physical therapists are there in your country? Are there opportunities for advanced education in pediatrics? Are there opportunities to specialize in pediatrics? And it also answered for input on what content is taught within your entry-level programs. The survey was only returned by 11 countries, representing only 4 continents: Asia, Australia, Europe, and North America. And in regard to curricular content, the most common responses were that normal motor development was covered, and common pediatric neurologic and cardiopulmonary conditions. A third topic was that pediatric interventions related to neurorehab and related to respiratory conditions were also among the content areas. Based on this survey, the Education Committee, which at that point was led by Barbara Connolly, and I was a member, we talked and decided that we needed more specific information from our member countries to get a better glimpse and global snapshot of pediatric physical therapy practice and education across the globe. So we developed the 2016 survey. If you look at the next slide, this 2016 survey, we decided to look at literature that was available and come up with ways that we could get more specific yes/no answers to content areas. We included, again, questions on general information on pediatric practice, the number of people who practiced in pediatrics, again, the availability of post-professional education in pediatrics, and the availability to specialize or become recognized as a specialist in pediatric physical therapy. But what we really wanted was a very specific curricular content table. We looked a lot at the literature. There was a wealth of literature at this very time from the section on pediatrics of the American Physical Therapy Association, which is now called the Academy of Pediatrics. And at the end of this presentation, you will see a reference list, which we did not do a full literature review. We looked at available current literature and we said, how can we put topics down that people can respond to so that we can get a better snapshot? We were very fortunate in this survey that 20 of our 24 member countries responded. So a really robust response rate with representation from Africa, Asia, Australia, Europe, and North America. So a truly global response. Some of our curricular areas, I wanted to give you an example or a few examples of the survey content. The one that was answered by 100% of the respondents as being covered in their curriculum was normal motor development. Then we asked, is normal sensory development covered in your entry-level curricula? 90% of our respondents said yes, and 10% said no. Is normal cardiorespiratory development included in your curriculum? 70% said yes, 30% said no. Is normal language development included in your curriculum? 40% said yes, 45% said no, and 5% had some other comments, but they did not substantiate either yes or no. And another example under examination techniques is age-appropriate examination of motor development included. And 95% of the respondents said yes, and 5% said no. So this gives you a little bit of a snapshot of the content we included and how we addressed that. So at this point, I'll jump back to this slide and let you know that at this point, as part of the education committee, Nikki and I participated primarily in saying, how are we going to interpret these survey results? The document that we're talking about today, the position statement on essential and recommended content areas for entry-level physical therapy education, we made a decision rule that we said if at least 50% of the participants in the 2016 survey said that something was important for entry-level education, we included it as an essential content area. If between 40 and 49% of the participants agreed that a topic was important for entry-level education, it became a recommended content area. So we went through the survey responses, we came up with essential and recommended content areas, and then Nikki and I used a mapping process, which has been used primarily as people have mapped to the ICF statement, and has also been used by myself and others in mapping curricular content to different guidelines like accreditation guidelines or pediatric content area guidelines. And there is one reference of how I use this with my colleagues at a university where I was the program director and pediatric faculty member, professor for many years. I am now retired, but that article came out and it is also listed in the reference list. So we used this mapping process to make sure that what we identified as essential and recommended content areas really were in parallel with and supported by and to the World Congress of Physical Therapy guidelines for professional entry-level education programs. We wanted to make sure that as a subgroup of what is now World Physiotherapy, that we were in parallel and in compliance with their document, and that we were just enhancing the content more specific to pediatrics. The end result, after Nikki and I became reliable with each other on this mapping process, is that we came up with the current statement, which lists the essential content areas, the recommended content areas, and then, lo and behold, we discovered that as the pediatric subgroup of World Physiotherapy, our survey was not totally complete, and there were some additional content areas identified in the World Congress documents that we felt had unique application in pediatrics, and we wanted to make sure that we address these and acknowledge them within our policy statement. So at this point, I believe you'll be able, and Nikki will give you a link later, to be able to access our policy statement on the IOPTP website. And our goal was that these guidelines could be used to provide guidance on what are the minimal standards for professional entry-level curriculum planning, curriculum development, and quality assurance processes related to content for pediatrics that should be included in entry-level physical therapy education. So that's how we got to the point we're at today. And I want to thank Nikki for the hard work she's done to get you the current statement, which will be available on the website, which she has added many pictures to, made it look much more professional than our original, and hopefully more accessible and available to individuals who are researching this area and would like to access this as a reference. So I'll let us go on to the next slide. So what's happened since we developed these things? I mean, this statement came out in 2019. Well, as Nikki has already told you, WCPT became World Physiotherapy. And as World Physiotherapy, or actually WCPT, developed a new education policy in 2019 that replaced that 2011 document. It has a very different, more general format than the 2011 document. And I do encourage you, if you work in entry-level education, that you go to the World Physiotherapy website and look this up. The one thing I will tell you is that the new document continues to emphasize that physical therapists need to practice with individuals across the age spectrum, from infancy, childhood, adolescence, well into aging and working with older adults. Again, emphasizing the importance of pediatric content. The other thing that World Congress also has another document on their website, the description of physical therapy practice. And that is the document that what we found that has supported what Nikki and I added as additional content areas. And the strong focus on that matches what goes on with the World Health Organization, and it supports the role of physical therapy in providing services related to health promotion and prevention. And again, it emphasizes that the physical therapist or physiotherapist should help individuals gain functional abilities across the lifespan. So again, from infancy through older adulthood, and emphasizing again the importance of addressing all age groups in our curricula. So with that, I'll move on to the next slide. And I believe we're going to turn this over to Yasser, who is going to start describing our essential content areas.
Thank you very much, Donna and Nikki. And before I start, I'd like to thank you very much for participating in this webinar. Also, I'd like to thank the members of the Education Committee of the IOPTP for developing this document, especially Nikki, Donna, and Barbara Conley, who happen to be here with us today. So in the next couple of slides, I will be talking about the essential content areas that should be included in entry-level physical therapy curriculum. Just to remind you, when we mean by essential content areas, those are the contents that 50% or more of the participating countries in the survey indicated that those are essential to include in the curriculum. And we're starting with what we call typical development of motor, sensory, cardiorespiratory, cognition, and also talk about social emotional functions. Those are contents area that considered essential. We said they were voted or indicated by more than 50%, but actually for those contents, 100% of the participating countries indicated that they are essential. Why they are essential, what we need to include, and what physical therapists need to know about typical development. They should know about typical development, including normal developments, what's typical, what's normal for a child, sequence of development, how the child or when the child achieving certain developmental skills and the milestone, and also the pattern of integration of those milestones. Why it's important? Because really they help physical therapists to determine if the child is functioning at the age that the child is supposed to function, or the child is not doing this function, the child has delay or has atypical development. They are important because they help us to identify what is atypical development, if there is deviation from normal or we call typical development. Knowing what's typical development help us to identify what's atypical development. They help us to fully understand human development. They help us to know developmental sequence. That can be also basis for evaluation. So some, and not all, physical therapists can use this sequence of development as a basis how they sequence their examination and their evaluation as well. In addition to that, they help us to identify problems in the child that the child has during the course of development. They help us to guide evaluation and the treatment. They help us to monitor child developmental progress. They help to really look at normal function at different ages. They also allow us to establish intervention program in some cases based on the developmental sequence. Next, please. Now, atypical development, physical therapists should know atypical developments, motor, sensory, cardiorespiratory function related to common pediatric conditions. It is important for us to know what's happening on those kids who present with atypical development, and also know based on the conditions. So physical therapists should know what's atypical development and common presentations seen in a child with cerebral palsy, how this is different than a child with a spina bifida, how this is different than a child with spinal muscular atrophy. Why it's important? This can help to confirm diagnosis. You got a referral for a child with a spinal muscular atrophy per se. You look at the presentation when you examine that child, and you can come to conclusion and say, yes, the presentation here, the deficits, the deviation is aligned or consistent with the diagnosis. Or you might say, no, that's not really consistent with the diagnosis. Let's confirm diagnosis or really do differential diagnosis. So when you do differential diagnosis, you need to know how each condition is presented. And I'll give you an example. If you have a referral and you start to see a child with a spinal muscular atrophy, knowing the signs, symptoms, deviations, presentation of a child with a spinal muscular atrophy can help you to confirm diagnosis or perform differential diagnosis. The example that I have, typically children with a spinal muscular atrophy, we didn't see high muscle tone. We might see low muscle tone. That's really consistent or really common with severity. So the more severe the child presentation, the more hypotonicity that we see or low muscle tone. So if I have a child with a spinal muscular atrophy during examination, I see there is hypertonia, which is not expectation of a child with a spinal muscular atrophy. I may come and say, wait, this is not consistent with the presentation of a child with a spinal muscular atrophy, and I start the process of differential diagnosis here to confirm or really say, no, that's not the diagnosis for this child. So again, knowing atypical developments will help us to identify those during examination, will help us to do differential diagnosis, will help us to confirm diagnosis. The other thing that's important also to plan to, when we set the plan of care, when we expect if the child, how the child will be progressing. I know that a child with such diagnosis, based on the clinical presentations and the knowledge of that particular diagnosis and condition, we should expect improvements. So I set my plan of care expecting improvements and work hard for that. Then I see other diagnoses where I expect decline in the condition. So at this time, my plan of care can be different. I can work in prevention. I can work in some improvement to certain extents. but it's again, knowing the conditions can help us to set the goals, to set the plan of care. So to summarize this slide, knowing atypical development help us to identify those atypical developments, knowing each conditions or clinical presentation for each conditions help us with differential diagnosis, confirming diagnosis, help us also to set the plan of care, prognosis, and expectation from each slide. Next slide, please. The other area that we have is that deemed essential is selection and also implementation of age-appropriate examination. When we talk about examination is essential because by doing examination, we can identify deviation, we can identify the severity of deviation, we can use those results to confirm diagnosis, can help with really identifying or saying about the prognosis, and also to set the plan of care. So it is essential for a physical therapist to really to be able to perform and select examinations techniques. When we talk about selection and implementation, they're all together, but they're different. So I might be able to do some testing, but I may not have the ability to select. That's not good. So a physical therapist should be really able to select. You have a list of examination, clinical examination, you have testing that you need to do. So I should be able to select the appropriate test for that particular child based on the child conditions, based on the age, based on also the clinical presentation of the child. The other things, I need to be familiar and able to select appropriate standardized tests. When should I use B-body versus I use the GMFM versus I use the other testing? I should be able to know what is the difference, when I should be using each one for each condition, for what age of the child, and so on. So selection is part, the other part I should be able to implement and perform those tests. What's also important is to be able to interpret the results of the test. So if I'm doing a B-body testing at the end, I should be able to come with interpretation of the result of the test so I can really have a good picture of the child. Next slide, please. The next slide is about intervention. Physical therapists should be able to select and implement age-appropriate intervention that includes strengthening, motor development, think about motor control, motor planning, integumentary treatments, cardiorespiratory, orthotics and prosthetics, functional training, and also electrical agents or physical agents. So those are lists of the things that deem essential for physical therapists to be able to do and perform. This is important. And some people may not be really familiar with those and may have a question, for example, why we should be familiar with integumentary system. And I give you an example. You will be treating some of the children with developmental disorders who may present with integumentary issues. Let's give you an example, a child with a spina bifida because of lack of sensation based on the condition, allergic to latex may end up by some issues in the integumentary system that you as a physical therapist should know when you are working with the child with spina bifida. The other concern from some people may say, why should they know about cardiorespiratory system? Because physical therapists should be able to work and treat those kids with respiratory disorders. We have some kids with respiratory disorders that come to physical therapy. Additionally, if you look at majority of kids that we treat in physical therapy, they may not have a primary issue of respiratory disorders. A child with cerebral palsy per se have motor disorders, neurological disorders. Later on, they develop musculoskeletal disorders. But also, although cardiorespiratory function is not primary problem at one point, they have cardiopulmonary issues. Example of that, difficulty in breathing, poor posture, If you look at a child with cerebral palsy, that child, because he have weak abdominal or core muscles, the rib cage will take different shapes. He will be elevated, he will be flattened, he will be stiff. So the child will have difficulty in breathing, in exhalation. So the diaphragm is not going to really elevate that much. The child is not able to expand that chest. So respiratory issue can be issue with some kids with cerebral palsy. What's important is if the child has those respiratory issues, that will affect the child posture, that will affect the child feeding, that will affect the child's speech as well. So we as physical therapists should know, in addition to the basic diseases or diagnoses that come with respiratory disorders or cardiac disorders, we also should be able to work with kids who have respiratory disorders as associated disorders. Next, please. The next slide is about family-centered care. And this became like really known a lot in 80s, where the World Health Organization identified that pediatric physical therapists should know and should provide services in a holistic approach in a family-centered care. What we mean by family-centered care is that we know that we work with a child, but that child, when you work with a child, you work with the parents, with the caregivers, with the family as well. So the concept of family-centered care is not to just work with the child, but also to work with the child, with the parents, with the caregivers, with the whole family at all. So when you address that child need, you should also address the caregiver needs, the family needs. And that's what we define by family-centered care. What the evidence is saying is that providing family-centered care is really important for the children with disabilities. It really results into better outcomes. Also, to be clear, when we mean by child or family-centered care, it doesn't mean that we work for the family. We work with the family. So things comes together that you as a physical therapist should work with the child, should work with the family, should collaborate with that child, collaborate with the family, and come to mutual goals that focus on both on the child and family as well. Next, please. The other essential content area that's identified by the members is culturally competent. So physical therapists should be really competent in providing culturally competent physical therapy. When we mean by that, you think about different things. You think about working with diverse population, how you have effective interaction, communication, understanding of the diverse population that we see nowadays. So that includes behavior, attitude, culture. You need to understand the culture that the patients, the child, the caregiver, the family is coming with. You need to also to understand the language and communication. So we should be familiar with that, not just familiar, but we should be able to be competent to provide the cultural cares that we refer to. So you understand the family boundaries, you understand the family, where they came from, the culture that they have, the language, the communication, and so on. So you can identify a better way to communicate with the family, with the child as well. That will help to minimize errors in communications and miscommunication as well. So for physical therapists to be competent culturally, think about first step, the physical therapist should have the desire and motivation to be cultural competence. The other things is cultural awareness. You should be aware of the cultural diversity, of the culture that the child is coming from, so you can understand exactly this. You should have a good knowledge of the culture of the child that you are working with. You should have the cultural skills to collect cultural data, to perform culturally based assessment, and also to provide culturally based intervention. Next slide. Okay. Age appropriate communication. You should be able to really have good communication skills, but also that can be appropriate for the child age. You should have that when you do the examination, the intervention, you interact with the child, interact with the family, you should have the good communication skills to interact with the child based on the age of the child. Next, please. Okay, now I'll hand it back again to Donna.
Okay, thank you, Yasser. And at this point, we're going to switch to what are the recommended content areas for inclusion in entry-level education related to pediatrics. And the first one, as I showed you a while ago in the slide, only 45% of programs indicated that they thought typical development of language and communication were very important to include in the program. At this point, we've made this a recommended content area. And if the physical therapist really understands the typical development of language and communication, that therapist should be able to successfully interact with an individual, regardless of whether they are an infant, a 3-year-old, a 7-year-old, or a 14-year-old. And in thinking of your own experiences with children, I mean, you realize that when you're trying to interact with an infant, it's your facial expression, it's the connection you make with your visual contact. And with a small child, it might be limited, making your vocabulary child sensitive and using the right kind of terms and words, or using words and examples that are important to children, whether they be from current movies or whether they be related to favorite toys. When you get into school-age children, you certainly don't want to talk down to them. You want to be able to relate at their level and maybe have them help you count or do math or, play spelling games that support their educational goals and acknowledge their cognitive and language development. And when you work with adolescents, of course, you've moved into a whole nother realm and you want to be successful in communicating. And again, not to really speak with the person at their level and acknowledging them especially in adolescence, as an individual who has important feelings and important things to communicate. And then finally, you need to be able to work with infants or with families and speak to families in a language and in a context that matches their ability to understand and work with you and communicate with you. And you need to let them know you are very open to their communication with you. So from that perspective, we've recommended you include typical development of language and communication in your curriculum. Next slide, please. Similarly, it's important that you look not only at atypical motor development, but also cognitive and social emotional development. This would allow you as a physical therapist to work more effectively with children who might have some sort of cognitive impairment. To work with a child with cognitive impairment, even if they are 12 or 15 years old, you may need to use instructions or language level that would be more typically seen with a younger child. When you look at conditions that affect social emotional development, you might have to be aware of working with children with social emotional disorders, perhaps on the autism spectrum disorder or with other pediatric conditions, that you need to relate at a level they're comfortable with and that is acknowledging and respectful of their space and ability to interact. If you can do this as a physical therapist, and we feel it's important for students to understand, you want the child to be an active participant in the physical therapy process, just the same way you do with any patient in physical therapy. So it's important for you to relate to that child cognitively and social emotionally so that they feel enabled to participate in the process of physical therapy interventions. Next slide, please. And then the third and final recommended content area really has to do with the laws and regulations that are related to services for individuals with disabilities within your country, your region, your community. And this allows you as a physical therapist, if you truly understand the laws, you understand what a child is able to do and not do. You understand very clearly that a child is entitled to adaptive equipment or is entitled to attend an educational program in their local community school. And so if you understand the laws and regulations related to services for individuals with disabilities or special needs, you can help that family and the child access the maximum amount of services available to them to allow them to be a bigger participant in their family and community. Next slide, please. And then finally, I wanted to mention the additional content areas that are important to include. And as Nikki and I looked through the WCPT practice expectations, which were available in an earlier document when we did this in 2000 with the 2016 survey results, we found there were these 3 areas listed below that had very unique pediatric applications to them and very unique content about typical participation and typical interventions for children and adolescents and infants. So we are recommending that as an additional content area, you consider health promotion, wellness, fitness, and injury prevention within your curriculum as it relates to children. And this goes right also along with the World Health Organization and what a major focus of what they're looking at. And, you know, health promotion activities really relate to and include physical activity across the lifespan and promotion of a healthy lifestyle to prevent chronic diseases as people move into adulthood. The second area, which has become certainly more important and more acknowledged in the recent decade or two, is interprofessional practice. Interprofessional practice, meaning you are part of the team, you work interprofessionally within and across each other's boundaries and supporting each other. This means in our more traditional way that we're part of the pediatric healthcare team. We work with physicians, nurses, nutritionists, multiple individuals, occupational and speech therapists across the healthcare team, or in a school setting, certainly across the educational team, the teachers, the classroom aides, educational administrators, and understanding the importance of how to include physical therapy for children with disabilities and special needs. And then finally, what we identified is as a physical therapist, you should be very skilled and aware of your role as far as delegating within the pediatric team. And among this delegation, this means that you are maybe working with delegating to parents, delegating to the child, a classroom teacher, an aide, or someone else within the team. Next slide, please. Okay, so finally, as in summary to our recommendations, the IOPTP truly recommends that in your entry-level physical therapy education programs, that pediatric specific knowledge, skills, and ability be applied across all aspects of patient management, patient evaluation, patient intervention, wellness and prevention across all aspects. We also recommend and support of WCPT, or now World Physiotherapy, and that evidence-based practice be supported within your educational content so that the things you're teaching, you can show the students the evidence that supports that something is a very valid and useful technique, or the evidence that supports that something is very commonly used within our pediatric practice, and it may not be fully supported by the literature, but here is the body of literature that we know so far. And finally, as across the lifespan, we want to make sure that the ICF model is supported in the educational content so that you take into account that you want the child and their family, you want the child fully functional and participatory in their family, their school, their community, and you want to take into account all of the environmental contexts that might be influencing the child's ability to participate fully in what's in meaningful and important activities. So with that, I believe I'll turn this back to Nikki to move us forward a little.
Thank you, Donna and Yasser. So we thought it might be a little bit of fun at this point for you to interact with us and answer some questions. So we've set up a couple of polls, a few polls actually. The first one, the question that we're asking is, in professional entry-level physiotherapy programs, should paediatric content, knowledge, skills and attributes be integrated across the program curriculum or be offered as a standalone subject or course? So on the instructions prior to that come with the log-on information, we asked whether you were able to download an app onto your phone if you had access to that, which is called Poll Everywhere. So if you happen to have that app and you are able to access it, could we ask you to open it now and log on to Nikki Milne? And whilst you're doing that, I'm going to switch over to the poll. Please just confirm that the poll has opened. Is it in front of you? Cherie, are you able to?
Yes, Nikki, I can see it.
Thank you. All right, so for those of you who have got the poll open, if I just give you a moment, can I please ask you, so log on once you're into Poll Everywhere app, if you can add the logon name of Nikki Milne, which is listed up here, and then start your responses. In a moment, we'll just share those responses. So from those of you who have participated so far, still seeing our participation increase. So the majority look like they're saying a standalone course. There's a lot of literature out there to tell us what's better or what's not, but what we do see is that those who have a standalone course seem to more commonly have a paediatric physio employed on staff, whereas those who have it integrated into the program don't have that as much. Okay, thank you. All right, so I'm going to just minimize that for a moment. And we're going to ask you to move to the second poll, which is, in a professional entry-level physiotherapy program, should all students be required to undertake a paediatric placement? So just give me a moment to pop that one back up. Okay, so same thing, if you can just log back onto that one, I'll reactivate the second. So 50-50 around about at the moment, saying that we should be undertaking a paediatric placement in entry-level programs. Okay, great, so sitting at 50-50 for our responses there. So thank you for those of us who are participating. If you still wish to participate in some polls, we've got a few more, and we'll be discussing some of these results at the end for those who wish to hang around and have some discussion about some of the content within the presentation. Just minimize that. We thought it might be nice also to share some examples of how we're integrating the ECAs or the RCAs into our curriculum. So there's no perfect solution for doing this, no perfect way, but this is just one way that we thought it might be nice to share with you. So we've selected ECA 2, which is atypical development of motor, sensory, cardiorespiratory function related to common paediatric conditions. So Yasser spent some time talking about the rationale behind the inclusion of this particular ECA. At our university where I teach, which is Bond University on the Gold Coast in Australia, we do a problem-based learning program. So nearly the entire program is based around the PBL model here. So the way that we teach our pediatric curriculum is at the beginning of the week, the students are given a problem, a PBL case. And in this particular instance, when we're talking about atypical development, we are talking about a young fellow named Ethan Agnelli. So in our problem of the week, we always use the name. We're very specific. We're not just saying if you had a child like this or like that. We're trying to make them really relate it to a real person, and we make it as authentic as we possibly can. And so this initial problem that they're given is in a room with about 8 or 10 physiotherapy students, and they've got one physiotherapy facilitator in the room with them. And they are presented with a number of triggers. And so this session goes for about 2.5 hours, where they are given one by one a trigger of information that should stimulate a certain line of thought processes for them. So in this particular problem for Ethan, our first trigger is all about him, all about Ethan and his family, his birth history and his developmental history. The second trigger is about his initial assessment by a physiotherapist. The third is about a developmental update 6 months later. And the reason we jumped to that is because of some of the social circumstances going on for Ethan, where his parents withdraw him out of therapy. So 6 months later, his grandmother becomes involved in his care and he returns to the physiotherapist. So he has a new assessment done. So we get to see some trajectory of his development. And then trigger 4 is about updated assessment outcomes and planning for treatment. So the students are given quite detailed information about the assessment findings for Ethan. And then the final trigger for Ethan's PBL case is all about family-centered practice and considerations for treatment. So the students are asked to start considering how do they make sure that they're continuing through to intervention using family-centered methods. And they're asked to really discuss that term and think about what that means. So that goes for about 2.5 hours. What we ask the students to do in there is to, from all of the information that comes from the triggers, to map that out in the ICF framework. So the students are collecting that information and trying to make sense of all of the detail that they've got and put that into the sections of the ICF. So they eventually get to a point where up on a big whiteboard in front of them, they see all the body functions and structures that are impacted for Ethan in this particular case, the activity limitations he might have, the participation restrictions that he might be having as a result of what's going on for him. And then they start to explore the environmental factors. They're making sure they're understanding those and acknowledging them, and also the personal factors for Ethan. And by the end of that first 2.5 hours of PBL, the students then have to have a list of learning objectives. So the facilitator doesn't give these to them, the group come up with them, and it's based on the conversations that are happening in their particular class. So this is just an example of some learning objectives that one of the groups came up with at the end of their triggers for their PBL case with Ethan. So in the PBL room, we have the physiotherapy facilitator, who is not there to teach anything at all. They're there to ask questions and to guide the students on a path of investigation. So they have a heap of prompt questions, and hopefully that gets the students to fairly similar learning objectives at the end of their session. So the pictures here are an example of what it would typically look like in a classroom situation. They're in small classes where they've got lots of whiteboards up and lots of post-it notes and things like that, where they're having discussions about what's important, what do they know, what they don't know. In COVID times, we had to flip to doing this remotely. So the picture at the bottom there is the students doing it remotely, where they've got multiple platforms open. So they do what we're doing now with Zoom, and then they also have, so they can still have face-to-face conversations. And then they've got their triggers open for their problem, and they've also got their ICF map up, and then they're documenting their learning objectives at the bottom of that. So after they get their trigger for the week, their case for the week, we then give them what we call in our university resource sessions. And Donna and I were talking about earlier in the week that we all use different language for this in different countries. So our resource sessions are a combination of learning packages, lectures, and also practical hands-on learning activities. So they'll start the week after they've got their case and their minds opened about this condition, and they're starting to think about what they do and don't know about this topic. We then start to give them some more information about certain conditions that might be possible for Ethan in this case. So it could be about autism, or it could be about neuromuscular disorders or developmental coordination disorders. So learning about the conditions and trying to make decisions about whether these things might be what fits the impairments, activity limitations and restrictions, participation restrictions for Ethan. We also then do a resource session, which gets a little bit more practical, where the students are asked to observe either via video, or we might have a child in the room with us where they're learning to do assessments on children that present like Ethan in this particular week. On other weeks, it's to match the case scenarios that come from the first PBL trigger of the week. So they'll observe these assessments. They're also asked at this point to not just consider what's atypical, but to also start to consider ECA1, ECA3, and ECA7. So we're asking them to look for things like their sensory, how are we assessing sensory systems? How do they know if it's typically developing or not, as well as cognition and their social emotional functions. Also, they're asking questions as they're observing these videos about what is this assessment. So we're asking them, we might give them a pro forma to follow, and they're also making judgments about the assessments. And then towards the end of the week, we try and do a more real life practical learning opportunity for them, where we might bring a real life child into the room with them. They're very brave. We have a lot of young children involved with our program who are becoming much happier with a crowd, and they'll talk with the students and show the students what their repertoire of skills are, and allow the students to actually apply some of those assessments themselves. We then examine these skills as well. So if we were examining atypical development, we have some examples of the ways we do that is through a written exam. So 10% of the marks of one of our subjects is about typical and atypical development. They've previously learnt about typical development, but we rapidly reintroduce them to that, and then they are straight into atypical development. So in this quiz, they'll be examined on things like their milestones, with a large focus on gross motor, but across each of the developmental domains. They're asked to calculate chronological age and adjusted age so they can make correct decisions about assessment. They're given cases that they have to identify whether the impairments, activity limitations, and participation restrictions are consistent with particular diagnostic criteria for conditions they've been learning about. And they need to be able to then go on and say whether they think that that's consistent with that diagnosis. And they're also asked to identify the inclusions for paediatric assessments based on some of these cases. So what assessment tool would they use? What outcome measures would they use that is appropriate for the child in the case they're given in the exam? Throughout the exam, we're asking the students to use ICF language and also identify the paediatric multidisciplinary team. So who would they refer to, and why would they refer to those members of their team? And finally, a big part of our assessment in our paediatric content is around our OSCE assessment. So it's about half of the marks. And after the students have had a number of PBL cases and resource sessions associated with that, they're then examined on their ability to assess and manage children who present from infants to young children, adolescents, and also transitioning into adult services. So they are asked to do a correct assessment, for example, of an infant. We are assessing their ability to safely and effectively handle and position the baby or the child that they're working with. And they're given staged release of findings of assessment in the OSCE, where they may have to deviate and change the way that they're assessing or intervening with the case in their OSCE examination. So sorry, I should have said this at the beginning. An OSCE examination is an objective structured clinical examination. So it's very practical in nature. Throughout the OSCE, we're also assessing their ability to communicate with their client and the family of their client in an age-appropriate way and in a culturally appropriate way. And finally, some of our OSCE stations we use video-based movement analysis. So we might ask the students to assess and make decisions about whether this is age-appropriate gait, if it's age-appropriate posture, maybe even they could move on to do things like completing AIMS assessments or motor assessments like TGMD3, where we might already have video capture of that. And the last piece of assessment that we do is an oral presentation. So we are asking the students to identify a particular condition that hasn't been covered in our subject. And about half of our students will do a pediatric focused seminar or presentation. The other half do adult oriented seminars. And then we ask them to do ICF mapping. They give in-depth information about the condition, and they show their ability to demonstrate family-centered practice in the way that they would assess and the way that they would treat or intervene with the client that they're focusing on in the presentation. They also have to show how they would change the way they do the things they do as a therapist as the case that they have. So let's say it might be Down syndrome, the condition that they're focused on. Then they might talk about how they would assess an infant with Down syndrome versus a child versus an adolescent or young adult. They have to refer to the tools they're talking about and the multidisciplinary needs of the particular client they're focused on. And also we're looking at their ability to educate their peers on the condition that they're focused on. So that's an example of, sorry, just go back to that. That's an example of how we might integrate ECA2 with touching in some of the other ECA 3, 7 and 1, it might have been, that we're integrating into our curriculum for that particular subject area as well. At this point, we'd like to just share a little bit more information with you about where we're up to. So we've obviously developed this new statement. We developed it first in 2019, and we have just recently published an updated version that you'll see now on the website. So I'll give you some guidance about that in a moment. But we wanted to let you know that we are also going to continue to do some more research on this topic. So coming up, in fact, we are looking to lock in our expert panel by the close of next week. So we have a 3 to 4 round Delphi survey is about to start, all about pediatric physiotherapy curriculum. And so whilst our curriculum statement that we've just talked about today was developed with all of our member countries and it had a large international focus, the responses were coming from the representatives from the member countries. So we would like to expand that information and collect more information about that through the Delphi survey with people who are embedded working in pediatrics or teaching in pediatrics. And so what we're hoping to do is to get an international consensus from our expert panel on the ECAs and the RCAs and whether these need to change or be updated in any way. We'd like to ask if there's a consensus on best modes of curriculum delivery or best modes of assessment. And we'd also like to explore what the facilitators and barriers are to the implementation of these ECAs and RCAs, because we might be able to then put things in place that will help support universities to ensure that they're implementing this pediatric curriculum into their programs so that all students graduate from entry-level programs safe and effective in their care and management of infants, children and adolescents. So we're currently recruiting to this study, to our Delphi survey. We are hoping to get about 50 people. Just so you're aware, if you're interested in this, the expert panel that we are looking for, we will need them to be able to understand, write and read in English language. We also would like to see our expert panel teaching paediatric content in a professional entry-level program, or has more than 5 years of paediatric physio clinical experience, is currently working as a paediatric physiotherapist, or is working as a senior paediatric physiotherapist in a physiotherapy role, or maybe a titled specialized paediatric physiotherapist, or finally, another criteria may be that they have paediatric physiotherapy related postgraduate qualifications. So they might have retired from clinical work, but be very knowledgeable in this particular area. So this is the criteria. If you meet any of those and you're interested in it, there's a link here to express your interest in participating on the expert panel for our Delphi. And there's also a QR link there, which you're able to scan on your phone if you've got QR scan capacity on your phones. And that'll take you to a very brief survey just to put some information about your name and what criteria you meet as for the expert panel, so we can reach out to you and hopefully include you in our expert panel. We figure if you've reached out to this particular webinar to learn more about it, then we probably have a number of you online who are very suitable for our Delphi survey. So we're just going to finish off before we open up for some discussion with a couple more polls. So if I can ask you to go back to your app on Poll Everywhere. And the next poll that we're going to ask you to answer for us is, in professional entry-level physiotherapy programs, how can students develop necessary skills for paediatric practice? So just give me one moment to pop that back up. Oh, sorry, my Poll Everywhere is going rather slow at the moment. Okay, so if you go back in, great, we've already got some responses. So in professional entry-level physiotherapy programs, how can students develop necessary skills for paediatric practice? Just give you, because this one you've got to type some words into it, I'll just give you some time to have a think about multiple options so you can keep answering into it. Right, I can see dolls coming up. I was very grateful for dolls during COVID. It allowed us to continue to teach practical skills remotely, which was fantastic. And I see the #1 response there so far is children. So having the opportunity to have real live children come into the room is certainly a massive learning opportunity for students, and tends to be one, from my experience, that they remember for the rest of their career. I see many graduates from our program here, and years down the track, they can remember the names of those children and what they were doing. Fantastic. So some really great responses there. So thank you for that. Whilst I bring up the next poll, you're welcome to keep answering. This is our 4th poll, just 2 more to go. I'm just going to activate this one. So in professional entry-level physiotherapy programs, should paediatric curriculum include focused learning in relation to infants, children, adolescents, and transition to adult services? So staying at 100% there. It looks like we've still got 100% there, no changes. So everybody agrees that we should be covering all of that. It's interesting in our country here in Australia, probably the one that doesn't get so much attention is the transition to adult services. But I do think it's particularly important, and it seems that each of you do too. Thank you. All right, so our final poll that we have for you tonight, this morning or middle of the day, wherever you are, nighttime for me here, is what can the IOP do to enhance paediatric curriculum in professional entry-level programs globally? So we'd like you to have at least a minute or two to be able to answer this, because we'll take this information back to the IOP Executive Committee and each of the education group, research group, practice group, etc., so that they've got this information. So please do enter anything in here that you think may be useful for helping enhance paediatric curriculum in professional entry-level programs globally. I can see webinars come up there and through webinars. That's fantastic. While you're answering that, I might hand over to Donna, who will give you a little bit of an update about some upcoming webinars that the IOP have organised. Donna, would you like to?
Okay, well, thanks, Nikki. And these are great responses. I want to thank everybody for participating. As chair of the education committee, I can tell you that some of the activities you've listed are certainly things on our strategic plan. And the webinars, which kicked off with this session today, have been our best forward advancement on our strategic plan because of the restrictions we've had over the last couple of years globally with health issues and with COVID virus restrictions. The International Organization of Physical Therapists in Pediatrics, or IOPTP, is going to be offering more webinars this year. Our goal is to offer 4 webinars a year. This was the first of those we'll offer this year. And some of our other topics that you should keep an eye out for, we're going to have a webinar series on physiotherapy in the school system, another webinar on physiotherapy related to working with children who are born preterm. And then we have one also addressing fitness and wellness in the pediatric community and the special considerations in that area. So please keep an eye on our website, our Facebook pages, and those of you who represent officers in our member country organizations, please share with your members of your organizations as soon as you see it, some of our webinars. We were very happy to see our response today, and we had so many people signed up. We realize it's very difficult to meet the needs of a global community with a webinar because, as Nikki pointed out, it's close to midnight for her at this point, and it's, you know, not quite 10 o'clock for me sitting here in the US at this point. And other times of the year, I live in South America, and it would be a little bit earlier there for me than it is for me now. So again, we're trying to meet the needs. We've picked this time because it matches what the World Congress tends to do, or the World Physiotherapy Group, for their webinars. And hopefully by recording it, things like this webinar will be available for everyone, as well as our next webinars.
Thank you, Donna.
So, Nikki, go ahead.
So we just wanted to, before we open for any discussion, or you might like to put some information in the chat, we just wanted to point out that we have a list of references that have guided the development of the curriculum statement. This is the new version of the statement that's sitting on the IOP website. So you'll be able to go straight to the IOP website and download the PDF of that if you like. And we also wanted to point out that this is the website link, and if you want to scan that with a QR scanner, then you're very welcome to do that as well. And just to point out that there are 2 Facebook sites associated with the IOP. The first one is the official International Organization of Physical Therapists in Pediatrics, where you'll see information being pushed out by the IOP executive there and the committees. But also then there's the Friends of International Organization of Physical Therapists in Pediatrics, which is an active site where a lot of people are posting things and sharing information about what's going on in their countries or asking for advice in other areas. So we keep an eye on that, and we're always looking for what people are talking about, what's hot topics, and we'll try and structure some future webinars down the track as well. So I'd just like to finish the official part of the webinar and thank Yasser and Donna for their contributions today, and also thank Barbara, who is online with us, who's done all the communicating and set up for you to register as well, and obviously has had a very large involvement in developing the curriculum guideline as well for pediatrics. So thank you very much to all those people. And finally, thank you to Cherie, who's been working very busily, Cherie Ziski in the background, admitting everybody and making sure everybody gets back on when they're dropping off. So I can see Cherie's been rather busy throughout the session. So thank you very much. And if anybody has questions now, then we're happy to stay and have a conversation about anything that you might be asking about. Okay, so this might go quicker than I can read it. So I can see.
Sorry, this is from me, Donna, and as chair of the Education Committee, I have posted my email address for individuals, and I know those of you who are organization officers have received an email from Sherry York, but we are currently expanding the membership of the Education Committee, and I want to thank some of our European members for being on the call today. But we especially are looking for individuals who might be willing to represent Asia and Africa. At this point, we do not have any members of the Education Committee from these 2 regions. So if you are interested, please, very much email me, and I'd be happy to talk to you more about the opportunity.
Thanks, Donna. So we'll just hang here now for a little while, and if anybody has questions, feel free to put it in the chat, or if you want to speak directly, then go ahead and turn your cameras and mics on and we can have a conversation. So we've got 10 minutes. I can't believe we're actually on time, 10 minutes to be able to talk through anything that you wish to discuss.
Nikki, there is one question in the chat from Richie. Nikki, how many weeks per semester and hours per week per student does Bond allocate to teaching your curriculum?
That's a very good question. I don't have the exact answer for you, but the way that we run our subjects at the moment, and this was somewhat impacted by COVID, but we run intensive subjects. So when our students start the subject I teach with pediatrics as the predominant sort of major topic area, we go for 6 weeks. So 1 week of that is assessment and 5 weeks is full-time in the classroom. So they're there from the beginning of the day till the end of the day and every day of the week. So they start the week with their PBL, they end the week with their PBL wrap up where they come back together in that small group, and the middle of the week is full of either resource sessions, lectures, practical learning classes, etc. And so that's the major focus of pediatrics in our program. And then we have a scattering of pediatrics across our program as well. So typical development, we teach right up front. So I'm actually teaching that in about 7 hours, 8 hours. So we do that with the first years very early on in their first subject, and then we pick that back up again when they reach us. And then in cardiorespiratory, they do some pediatric cardiorespiratory in there as well, but we cover the bulk of the rest of the pediatric content.
Sorry, Nikki, just going along with that, there's another question. When this major area is selected, so PEDS, in what year of studies is it offered at Bond?
Yeah, in our course here at Bond, we're a 2-year postgraduate program, so Doctor of Physiotherapy program. There's not, I know that's very common in the US, but there's not that many Doctor of Physiotherapy programs in Australia. I think we have 6 now, and the rest of them are either bachelor degrees or master's degrees. They're all entry-level degrees, though, that we do. Well, here it's an entry-level degree. So when our students are doing pediatrics, it typically is in the last year, so the second year. So they'll have done a 3-year undergraduate in some form of health science, usually exercise science in our area here. So exercise science, and then they do first year of physio, second year of physio. So it's usually second year, and it's usually after they've done some placements as well. So they've been out into the real world and done some placements for their adult musculoskeletal and cardiorespiratory. However, because of COVID and because we had the opportunity to keep teaching skills with dolls, we've been moved into first year. So that's been a real challenge for us, teaching pediatrics early before they've had the scaffolding from the more core subjects of musculoskeletal, cardiorespiratory, and neuro.
This is Donna. I'd like to say that also the program I had been involved with prior to my retirement, we did the same thing. We had a 3-credit-hour pediatric physical therapy course offered about in the middle of the program after there had been 1 clinical placement. But in the very first units that they covered in their first year, we had a lifespan development course where we really tried to address typical development across the lifespan, and we introduced all areas of development, including cognitive and, kind of basing it on social emotional development, and helping people understand how they could use lifespan development skills to work with individuals from infancy through older adulthood. The other thing that we did is for topics that were really unique, and in the US it's not as major perhaps a content area as in other countries, but in our cardiorespiratory physical therapy classes, we then had we have a special unit on pediatric conditions unique to that. And the same thing within our neuroscience courses, we have specific units. So there is one course that focuses more on evaluation and intervention techniques specific to pediatrics and some pediatric conditions, but otherwise there is content integrated across multiple courses in the curriculum. And I think if you look at the article that was by myself and my colleagues at Midwestern University, you'll get an example of how that was mapped across the curriculum.
And from my experience, is not unique or not different than what Nikki or Donna mentioned. And in general, I used to be teaching pediatric contents in 2 former programs. I have a pediatric course dedicated for pediatrics only. It's a 3-credit course, total of 45 contact hours. But also we have pediatric contents scattered through the curriculum, similar to what Donna mentioned. So we have a course about lifespan development that span between children all the way to geriatrics. So big part of this one, almost 1/3 of this one, is talking about pediatrics, pediatric development, pediatric skills as well. Then we have another course about motor control, which talk about motor control, including adults, including geriatric and pediatric population, with some small sessions specific to pediatrics. Also, the cardiopulmonary course has 2 sessions dedicated to cardiopulmonary conditions in pediatrics. The musculoskeletal course has 1 long sessions, 4-hour session dedicated to pediatric musculoskeletal conditions.
Thank you, Yasser and Donna. I see Barbara Connolly has also got a comment there saying, in our Poll Everywhere survey, the definition of paediatric placements is unclear. And Donna and I had that similar conversation the other day and trying to come up with a term that works for all the countries. So Barb has said, all of our students had hands-on experiences with children, assessment and interventions, but not all have clinical internships. And that's pretty consistent with what happens here in Australia as well. And that's purely because there are not enough paediatric placements. So for any of our clinicians out there, we really want all of our students to have placement experiences out in real world, authentic placements where they spend a prolonged period of time. But unfortunately, we can't find enough of those where students get those experiences. And that's the reason that we bring children into class, so that they can actually do assessments and work with children in class as well. But it's obviously logistically difficult and challenging for the educators to be doing that in the universities, especially during times like COVID.
Donna, yeah, there's one more question in the chat. Donna, could you please specify what your specifications are for becoming a committee member?
Yes, and I was going to respond to that, but on the chat so people have it. But the first and most foremost requirement is that you are a member, you represent a member country of the IOPTP. So we currently, have multiple countries. If your country is a member, that means you have a pediatric organization that is recognized and has joined membership of the IOPTP. So we are restricted to members being representatives of member countries. It is very helpful if you have experience in either entry-level education, advanced level, post-professional education, or clinical education, and you would like to participate. We have initiatives where we're looking more at how can we expand some guidelines into the clinical education arena? How can we do more to provide web-based resources? Or how can we provide information about webinars or other things to individuals who are interested in gaining more information about education related to pediatrics? So again, if you represent a member country and you're interested, please let me know. Again, my email is djcech22@gmail.com, and I'd be happy to communicate personally with any of you who are interested.
And somebody has just asked for the link, I think, for the statement itself. So I've just popped that in there for everybody who's attending the meeting. So at the moment it's sitting on the landing page of the IOP website. Any other questions that people would like to ask either through the chat or in person? Maybe a few more coming through. No. I can see someone's asking for our email, so I'll just pop that in there as well. And Yasser, I think Donna's already done it, if you're able to do it, that would be great. Okay, well, yes, we will be sending out a bulk email with the recording link. So hopefully that's all recorded into the cloud. And we'll close that recording off in a moment. And we'll also send a copy or a link for you to download a copy of the statement of the IOP website. I'll probably do that by the close of the week. Sorry, it's the middle of the night, so I'll wait till tomorrow, I think. I'll also, if it's helpful for people, just try and download the copy of the information from our polls so that you have access to that as well, because that may be useful for some of you who are looking at developing curriculum within particular areas or universities that you might be working at.
I see a new question about explaining how we communicate with different countries to obtain information. The IOPTP has regular communication from our president, Sherry York, currently, to the presidents of all member organizations. And that updates you as to what is happening, what kind of opportunities are available. And as Nikki shared earlier, we have the 2 Facebook pages, and we also have the IOPTP website, which is open to individuals, where we regularly post information. If you are not a member of a member country and you're an individual, the Friends of IOPTP Facebook page is very active, and I encourage you to keep checking that. The other thing, it's very hard to communicate across the globe, which is why I was so excited to see participants from so many places. I apologize to my co-presenters, but on a personal note, I was especially encouraged by our participation from Central and South America today. I currently am participating in some efforts in South America, and unfortunately within the IOPTP, we only have one South American member, Colombia, so thank you for participating today. And the country where I am currently living is not a member, and I've been working with them to try and figure out how to do this. But, please get in touch with me if you do represent anywhere in South or Central America. I'd be very much interested in hearing from you and hearing what you're doing related to pediatrics.
Wonderful. Maybe just a couple more moments and we'll see if any more questions come in, or if anybody's wanting to turn their mics on and camera on, you're welcome to do that too.
This is Barbara Conley. Great presentation from all of you. I had put on the question about member organizations because there were a number of people that are not members of IOPTP and wanted to know how to become a member. We do not have individual membership in the IOPTP. Our organization is an organization of member organizations who are the pediatric branch of the WPT member organization. So if you are not a member of the pediatric group within your country and not a member of the WPT organization, you might want to investigate that because that way you automatically become a member of the IOPTP.
Thank you, Barb. Okay. Well, I think there's probably a few tired people out there who are participating and a few of you who need to get on with the rest of your day as well. So we thank you very much for joining us for our very first international webinar from the IOPT, and we look forward to seeing you online for others as well. So keep an eye on the website and the Facebook pages, and we'll be advertising the upcoming ones as Donna spoke about soon. Thank you.